compared to hepatitis B, hepatitis C, most of the people go on to become in a chronic state, and out of that chronic state, almost 80 to 75 to 80% of the people go into chronic state once it gets infected. Out of those, 20% of the people will go into a cirrhosis and then leads to an hepatocellular carcinoma and die from that unless they get a liver transplant before they get into the problem. So this is the leading cause of liver transplant in the United States. These are some of the statistics from the United States. Most of the people before 1990, before this was discovered, it was actually infected. If you look at here, 1990, that's where this diagnosis was first actually, the hepatitis C was discovered. Most of the people were infected before then. Then they continue to, of course, since it's a chronic disease, the numbers continue to be the same. And you can see these are the chronic infection. These are the total number of people infected if you look at antibodies. But these are the people who carried the infection. And these are the people who had the cirrhosis. And this they are projecting up to 2030. It's going to be one of the major causes of liver transplant today in America, and also one of the major causes of liver-related diseases in the United States. Same thing here, this graph shows that the decompensated cirrhosis keeps going up. Since these people are infected somewhere here from 60s to 90s, and these people are now showing up after 30 years, going into decompensated cirrhosis and hepatocellular carcinoma. This is some of the statistics from United States. Almost 2/3 are men who are infected, and 1/3 are females. And it varies from different groups. If you look at IV drug abusers, almost 80 to 90% of them carries the hepatitis C, chronic hepatitis C. And you look at the children, it's much, much rare. And you look at HIV, quite a few people who got infected. So it's a different groups of people, how they got infected with hepatitis C. Now, to give a simple estimate, look at HIV, compare with an AIDS. It is 4 times more prevalent, 3 to 4 times more prevalent. People have hepatitis C than HIV in America. And one of the common causes of deaths now for the HIV people are hepatitis C infection. They get very fast cirrhosis and actually dying from cirrhosis than dying from HIV disease. So it's main cause of death in the HIV patients, hepatitis C. But nobody talks about it because it's not really politically made. That kind of, there's so much money they spend on HIV. Very little money is spent on the research for hepatitis C, even in the United States. This is hepatitis C again. Looking at the genome, there are 6 different types. The common one in the United States is genotype 1. In India, we have type 3 is the common one. And there are some areas where type 1 is also common, especially in Andhra area. We have both type 1 and type 3. The reason why these types are mentioned is type 1 is extremely hard to treat. Type 2 and 3 are easier to treat. So as we go further, we will see why we are talking about these different types. Now, the symptoms for acute disease, as I said, was very, very rare. You rarely see a patient with the acute hepatitis C. Last 20 years of my practice in the United States, I haven't seen a single patient with acute hepatitis C. Most of the people actually complain of fatigue, weakness, tired, fever. This all, any viral disease can give, and they go away within few days, and they don't even know they had an infection. Now, the risk factors, before the discovery of the hepatitis C, blood transfusion was the major source of hepatitis C infection. But today, in 2011, the most common cause for hepatitis C infection in developed countries as well as in India is IV drug abuse. IV drug abuse is the most common cause of the hepatitis C infection. And then there are some groups like hemodialysis, and people who have sexual orientation, men-to-men sexual orientation. Some of those people are people who have more sexually transmitted diseases. These are all the people who have high risk, and tattoos, things like that. Now, the irony of this hepatitis C infection is, since people doesn't know what the symptoms are, and they're just very transient symptoms if they are, most of these people are not diagnosed. They are diagnosed only when they go to a physician and they check their blood test, they find abnormal liver function tests. That's where they check for different viral hepatitis. That's how they diagnose in United States. Here, I don't really I don't have a clear picture of how they diagnose, but it has to be something like that. Patient goes for some kind of testing, they find the abnormal liver function test, they check for hepatitis B and C, and they find this hepatitis C presence. And the screening for hepatitis C is, originally you just check for an hepatitis C antibody as a screening. It's a very sensitive and specific, almost 99% sensitive and specific. Once you make the antibody present, either they had a disease or they are still having a disease. Then second step you go for is check the quantitative hepatitis C RNA. If they have hepatitis C RNA positive, that means they are chronically infected. If they are negative for hepatitis C RNA and positive for antibody, these people had an infection. They cleared the infection already. So these two tests are more than enough to do. Then you can check for genotype if they have chronic disease. To treat these people, what type of treatment you need to give, how long you need to give. And these are some of the guidelines which has been published by the American Association of Liver Disease, Society for Liver Disease. And basically, anybody who has a chronic hepatitis C infection with elevated liver enzymes and the liver biopsy shows any activity, they need to be treated. Otherwise, they can actually go in and develop a cirrhosis and hepatocellular carcinoma. These are some of the factors associated with fibrosis. Number one, if they get an early infection, the chance of they getting into cirrhosis is very high. How long these people have, as we said that 20 to 30 years it takes. That is another factor. Some of the other factors, alcohol. If people are drinking and they have hepatitis C, they go very quickly to develop the cirrhosis than people who doesn't drink. People who have diabetes and who are obese, having a fatty liver, they are also at a high risk to actually make the disease go much quicker. You can see there the normal liver and the cirrhotic liver, how they look. This is the normal liver, this is the cirrhotic liver. Let me go back here. These are different stages of fibrosis, where you can see the stage 1, very, very limited portal area fibrosis. Here you are connecting portal to portal fibrosis. Here it's a lot more fibrosis. Here you are forming already cirrhotic nodule with an hepatitis C infection. Now, there are some requirements before you treat. You need to make sure these people are not obese, they are not diabetic. If they are diabetic, control the diabetes. If they are drinking alcohol, tell them not to stop drinking before you start the treatment in these people. And if they have an HIV infection, you need to treat the HIV infection. This is some of the data we have on hepatitis C treatment with PEG interferon and ribavirin. These are one of the mainstays of therapy still today in India. And using once a week PEG interferon and take 2 times this ribavirin can give you, these are the results. If you take all genotypes, you have almost 63% of the people who can get what we call sustained viral response. We used to call sustained viral response in the past because we are not sure whether this is a cure. Now in 2011, we do call this sustained viral response as a cure. If you do achieve the sustained viral response, you are almost cured. So we just talked about sustained viral response. What is sustained viral response? Once you finish the treatment and wait for 6 months and recheck for hepatitis C RNA, see whether you have it in the blood or not. If you don't have that after 6 months of treatment, and you call that as a sustained viral response. I'll give you some terminology here. We'll go through. For scientific purposes, they actually made several kind of how you treat these patients. There is something called rapid viral response. Once you start the treatment, within a month, if the viral load is completely gone and you have a 0 viral load, you call it a rapid responder. Then you have a different, you can say ERVR, that means extended rapid viral response. Then you have early viral response. If they respond by 24 weeks, you call early viral response. These are the things we use in treatment when we are treating the patients. This again in the picture we are showing here. If somebody responds within a month, that's a rapid viral response. And most of these people really continue to keep it. They extend their rapid viral response, majority of them. and they achieve the sustained viral response. They never get actually back the virus. But you cannot stop the treatment right here. You have to continue. If it's a genotype 1, almost a year. If it's a genotype 2 and 3, at least 6 months. Then these are the people who responded by 12 weeks or 24 weeks, but they can continue to have a sustained viral response, but some of them can relapse, and that's the relapsers. Some people never respond. They still continue. If you have 5 million viral load, they actually come down to 1 million or 500,000, but they don't completely go to the zero, and these are partial responders. Some people never change in the viral load. Whatever you do, those are null responders. And this is the genome of the hepatitis C. Why I'm showing this is, in the genome, we have a different type of proteins where we use the medications to treat the disease. These are the core. We don't know how the interferon affects, but we have targeted therapy now in 2011 available. These are the non-structural proteins. One of the major one we use is the protease inhibitors, which has been approved in May this year. That actually increased the response rate significantly, especially for type 1, which is the one hard to treat. That's why the genome we are showing here, these are some of the proteins they attack. And there are 2 types of protease inhibitors. One of them, here they showed boceprevir. And this is the drug made by the Merck. And this medicine, they give 3 times a day, almost 250 milligrams. 1 gram in the morning, 1 gram in the evening, 1 gram in the afternoon, 1 gram in the evening. Every 8 hours approximately you have to give. Along with the peg interferon and ribavirin, you cannot just give a oral therapy with these medicines. You have to add this to the peg interferon and ribavirin. Otherwise, this medicine is not going to do any good. So in this particular study, they choose to give in a 1 month actually with just a peg interferon ribavirin, then started with boceprevir, and peg interferon ribavirin will continue. This is a response-guided therapy. If you are free at 8 weeks and 12 weeks, if you are free at 8 weeks, means the viremia is cleared at 8 weeks, and you stop the therapy here. If viremia is cleared at 12 weeks, you continue the treatment with peg interferon ribavirin after 36 weeks. In this one, they just gave the boceprevir and peg interferon ribavirin for 48 weeks. These are all the people only with genotype 1 because they are hard to treat. And these are the results. Whether you use the response-guided therapy or continue using the boceprevir for the last 48 weeks, the response is more or less same. In other words, they are telling you, you don't need all the time boceprevir because the medicine costs almost $48,000 to give for the 24 weeks. So that's expensive. So you cannot afford to give this medicine for a long time. So they're trying to see how well you can actually shorten the therapy. That's why their response-guided therapy is as good as actually using the boceprevir all the way for 1 year. Same thing, the relapse is much, much lower. Here, they are looking at early response versus late response. In other words, if the person is cleared the viremia by 8 weeks, their response is excellent, almost 100%. 96% of the people cleared their virus and they continue to have the same. They are cured. If they respond by 12 weeks instead of 8 weeks, they wait for 12 weeks to clear the virus from the blood. Their actually response is much less. Here, the long-term boceprevir seems to have a little bit edge over the response-guided therapy. This is another drug which is made by another company, T.reddy. This medicine, they start in the beginning instead of, that's how the design was actually. It has nothing to do with why they gave 4 weeks without protease inhibitor. Here they use T.reddy for 8 weeks versus 12 weeks. And with this study, they decided to go for 12 weeks rather than 8 weeks. Again, they are looking at placebo just with a peg interferon and ribavirin. Here they are giving 8 weeks of T.reddy and then continue the peg interferon ribavirin. If they respond in the first 8 weeks, then they stop it here. It's within 24 weeks. You don't need any more treatment after 24 weeks. If they don't respond within the first 8 weeks and they go to 12 weeks, then they're extending the peg interferon for 48 weeks. Here they continued the whole treatment for 48 weeks. And the results are shown more or less the same. If it is an early if it's a rapid viral response, again, within a month, if you clear the virus, the chance of cure is almost 90+%. If they take more time to clear the virus, then actually it goes down. The percentage of response goes down. Those were the people, what we showed was actually the naive patients, patients who were never treated. Now, this study shows with people who were treated before with peg interferon and ribavirin, either they responded and again relapsed the disease, or they didn't respond, they partially responded. Those are the genotype 1 people they used and did the same study with the previously treated patients. The results are more or less same. The effect is same. Bosuprevir does actually help in the people who doesn't actually respond before with peg interferon ribavirin. So, in other words, there is a good chance if they didn't respond before using these protease inhibitors, you will get a cure for these people. And you go to the same, this is again with bosuprevir, they are showing prior relapsers and prior partial, different type of people who, these are the people who relapsed after the first treatment, and if when they were treated, there was almost 70 to 75% of the people who really responded. People who partially responded original treatment with peg interferon ribavirin, there are almost 50% of the people actually did get benefit with using the protease inhibitor. Similar story with, here they are showing early responders versus late responders. There is a difference between the two. This is with bosuprevir, with again going with if they had a different stages of fibrosis. If you have more fibrosis, chance of clearing is much lower. If you have low fibrosis, chance of clearing is much higher. Similar studies have actually, the teriparatide shows the same thing. If you have already been treated with the peg interferon and ribavirin, either you relapsed or you are not responding properly, adding this teriparatide seems to definitely improve their success, and they did get cure in different stages. Again, here they show the cirrhotic patients who were treated, not responded, but using this drug, they did get a significant response. All these treatments have a lot of side effects. It's not easy to treat. They are not only very expensive. One of the studies I looked in, peg interferon and ribavirin costs almost 4 lakh rupees in this country to treat one patient. That was cheapest. They do not have protease inhibitors in this country yet, but as I said, it costs almost $50,000 to one course of treatment for each person with these protease inhibitors. But all these medicines do carry a lot of side effects, and these are some of the side effects. And when you use a peg interferon ribavirin, you can see there are a lot of side effects itself with just peg interferon and ribavirin. When you add the bosuprevir, some of the things really add up the side effects. Anemia was 29% of the people get anemic when they do in a peg interferon ribavirin. Here that goes up to 50%. So we really have to monitor these people very closely, actually sometime weekly, to make sure they are not going, and use some of the medications to improve their anemia and also neutropenia, things like that. And these are some of the comparisons with both peg interferon and adding the bosuprevir, what kind of side effect they have. And this is the same thing again. With the teriparatide, one of the major side effects other than just peg interferon ribavirin is the rash. Rash is very significant. Some of the people we have to stop the treatment, and almost 56% of the people who were treated developed the rash, skin rash. Some of that is very, very significant. I'll show you some of the pictures here. This is the mild rash, and you can see that it's actually extending papillosquamous kind of rash. This is one of the severe rashes where you have to stop the treatment. Otherwise, they can even go into Steven Johnson's kind of picture and die from the disease. So this is one of the major effects of teriparatide. So it is, now we have a good therapy, but it is very expensive, and also it needs intensive follow-up by these people. We usually have a couple of physician assistants with us when we treat these people. They monitor these patients, calling them home, trying to see what they are, and bring them to the office every week or every 2 weeks, depending on how well they are doing. And then monitor their blood count, their thyroid functions, and check them for their rashes and all these things. That way, we are not missing anything, and the people don't. We had patients who had acute heart attacks and things like that because they become very anemic if you don't follow them. Thank you. If you have any questions, I'll be happy to take.